Arganissima, New York. Your exotic skin, hair, and beauty source, and your one-stop shop for all your natural and organic skin and hair care, featuring authentic organic Moroccan oil and prickly pear seed oil and much more. Bringing you only the best, straight from the source and proudly produced in the USA. So what are you waiting for? Shop today at www.arganissima.com. Arganissima, New York. Your beauty is our duty.
Folks, welcome back to the iHealth channel, iHealth Radio, with your host, Hurricane H. New day, new show, new topic, new guest. And today we're going back to the basics, to the primary care world. And with me, I have a provider, an author, and someone's going to share with us some real insights and about patient, education and things that have been impacting the primary care world today. And we're going to maybe interact a little bit with some insurance, dilemmas that he might be enjoying or not enjoying in that way. But anyways, I have with me Robert Barkett, and he is a physician who has just put a book. I think he's put a book a while ago, right? I mean, it's not new, right, doctor?
It was published in February of 2022.
All right, so it is recent. Well, again, with me, Robert Barkett. So, Robert, welcome to the call, to the show, to the information here, to the platform. So, how are you first? Let's go over that.
Well, first of all, Hurricane, I'm so glad you had me on your show, and I appreciate you inviting me. And I'm just really anxious to get information out to the normal patients from just an internal medicine standpoint, from a small Midwestern town, trying to get out some of the old school medicine to the current technology, and patients can take a little bit more control of their medical care.
All right. Well, I have the honor and the privilege to have you and definitely you're bringing us a different angle. And you're right. I think we don't talk much about primary care and what's going on. And the patients in general, people in general, are not as educated enough as to how to handle, the services in general, the access, and what's good, what's not good for them. And you and I had a little brief discussion about, how things have been diluted a little bit, and that, it's not the same. Medicine has changed a little bit. It's a way. And you come from a doctor family, so you have a little bit of a history with medicine, and you go back in time. And so we please guide us through the concept. First of all, the name of the book, that would be great, so we know what the book is about.
It's called Simple Medicine, No More Google Searches. Simple Medicine, No More Google Searches.
I love that. That's as simple as it gets. You can't make it any simpler, right? Simple medicine. I love it. And
right.
So we're going to talk about the Google, no more Google searches. So I guess no more WebMD or something. Is that what it is?
No, my God. WebMD confuses me. So that's part of the reasons why I wrote the book.
Well, listen, nothing against the guys from WebMD, but the fact is, you're right. It is, you need to know what you're looking for. And common folks, we all tend to become, Google doctors,
right?
Or like,
exactly.
almost get in the Google diagnosis and prognosis and all that stuff, and try to educate ourselves. And sometimes that could be a big mistake, because a lot of illnesses, a lot of problems can be very similar in the diagnosis. And unless you do further things, unless we go to an expert, we make mistakes. And sometimes it can be chaotic, because you can take the wrong medicine, you can have the wrong stress. You can do a lot of crazy stuff. So I love the concept.
That's interesting that you say that, because, we had talked a little bit. One of the impetus of the book is actually a patient story. And I told you, through the years, I rounded with my father in the 1970s, and we'd go to the hospital, and my father knew all the nurses, all the other surgeons, subspecialists. He knew that, the housing staff. And then as technology and subspecialty is advanced, your primary care doctor is no part of that hospital system. But also, when my patients now come into the office, they've already done their Google search, and I ask them what's wrong, and they usually give me their diagnosis versus their symptoms. So it was several years ago, and I had he was a man that was an educated man, and he was a teacher, and he only came in for his regular appointments, but he needed to be seen that morning immediately because he was dying. So he came in because that night before he had urinated a little blood, and he had renal cell kidney cancer, and he was going to die in about 3 weeks. So he comes in, he's agitated, he's flushed, his hair's on fire, and really he's just ready to jump off the cliff. So, because he read it on WebMD or, one of the Google searches. And I said, you know what? I gave him what the most common problems were, probably a kidney stone or something of the sort. So we did the ultrasound, we found a stone, and, several days later, he came in for his follow-up visit, and he brought in a sign for me, a poster. And the poster said, "Don't confuse my medical degree with your Google search." And I just burst out laughing. And, when I think about it, all of a sudden at that time, I'm like, and I've been frustrated over the internet and instant gratification or instant diagnoses. And I tell you, that was another starting point for me to write this book to help patients navigate their healthcare.
Well, that is a very interesting story, and I'm pretty sure that is a story of many. I might even be guilty of that too. So let's just be clear about that. I think I've made that mistake once or twice, but I have to say, no matter what I read, I always kind of ask the right question to my doctor and make sure that he gives me the final, because I go in with an opinion based on what I've read, but it's usually a wrong one.
Right.
So I've learned to actually, just do the research just to get a little bit more education about things. But at the end of the day, to your point, diagnoses can be, multiple, and only you can determine that based on the work that you do. I mean, you can send them to x-rays, to different things, sonograms, right, whatever, all these things that they have to do. And then eventually get the right blood work, many things. And that's the thing. We all, just like the flu, I got the flu. Is it corona? Is it the flu? Is it allergies? Is it this? I mean, it can be all similar. Is it a cold? We don't know. Yeah, unless you test, you don't know. So it is a difficult task. And depending on also the level of education of folks, sometimes not being too educated can be a good thing, because you're not going to go crazy. But sometimes you think you got this. And what do I know? I mean, I can bypass the doc. I can figure out and just self-medicine myself and self-medicate, and then you get into a shock problem. That's not a cool thing. But so that's what we're here today. Really, the idea, first of all, thank you for putting that book out, because first of all, obviously information on Google is great. There's plenty. But understanding, it's like everything else. You can go to library. If you don't know what to do with the information, nothing is going to matter. Right. Like you can go you can shop all the food you want. Doesn't mean you're a chef. I mean, you can go to the kitchen. Doesn't mean you got to do a good cooking. Right? Same concept. You get a lot of information, but understanding how to use the information correctly and apply correctly, that's always going to be a problem. I mean, we use that in business all the time. I do consulting sometimes, and when you do consulting, you give them a lot of strategy, planning, all the stuff. And then they wind up doing something different because they don't apply correctly, right? It depends on who's executing.
Right.
And then here in medicine is worse, because now you're talking life and death and long-term issues. And of course, we don't want that. We want to educate people properly. We want them to know what to do, how to do it, what are the steps, what are the processes, and certainly avoid all the mistakes that are very common. So your book is rich. There's so much there, but I love it. Simple medicine, and let's keep it simple. To your point, I mean, medicine is a lot of things too. I mean, primary care is preventative. You want to be able to see your primary doctor.
Correct.
Your workup, and then what do you call them, the annual checkups and things like that. You don't want some people, again, to your point, you got a little bleeding. Oh my God. I mean, you can have some. This is the common to hemorrhoids are very common to everybody. Now that doesn't mean you have colon cancer, God forbid, but you can still.
Well, I had a patient today. came in and there was a pool full of blood, bright blood, and in the toilet bowl. And of course, first thing they said is, "I've got colon cancer." And I'm like, probably not. It's bright red blood, one time only. I think it's probably just a hemorrhoid. You look and you're like, there's the hemorrhoid. But I think a lot of things goes to the primary care having to be the quarterback of the team. And one thing is you have to develop your relationships with the patient. So your patient. Now, luckily, I've been in practice 29 years, but my practice does fluctuate. But for the most part, my patients are loyal, and I know which ones sometimes need a little bit more hand holding, and they're going to come in and just give them reassurance. And then when they do walk in the door and I observe them, I know I better, be much more concerned, because there probably is something really going on here. And that's the beauty when you see your patients. I don't want to, I think medicine's getting a little watered down now. I think at bigger institutions, a lot of medical practices now are being owned by hospital systems, and I am so against that. They now, a lot of my patients will say, "I see Dr. X," but I've never seen Dr. X, because I see a nurse practitioner, I see a physician's assistant, I see, and I've really even not met Dr. X. Well, that's just not the way medicine should be. It's the whole thing is about a relationship with the patient and education. And the other thing, doctors, now that I'm older and have been a patient myself, when I go to another doctor, you think I'm a little bit educated, but you get in the office, you think, something's wrong. Your mind's racing. The doctors say it could be this or that, and you're like, oh my God, and then all of a sudden my common sense goes out the window, and I walk out of I'm dazed, like Muhammad Ali had just hit me right in the nose or something, And so as much patient education as I think I give my patients in the office, I know when they walk to the car, they've already lost 75% of that information. So now when they go home, they have my book, say their example diabetes, and now their hemoglobin A1C. And even though we just discussed it for a minute, that it's a 3-month check on their sugars, it doesn't matter if they ate McDonald's that morning, what that test means, or what a urine protein is actually checking for. So now it's just purely a reference guide. So when you see your doctor and they tell you something and it's a common condition, you just reference my book and it's there.
Wow. So it's actually a resource. I mean, not only
it's a resource. Yes.
Yeah. So basically you can just go down to the element and figure out what you missed.
Absolutely.
I love it.
Since I've been in practice, at primary care, and I went through the most top 10 common problems you see your primary care doctor for, chronic problems like hypertension, high cholesterol, atrial fibrillation, congestive heart failure, depression, migraine headaches, dementia, and so I wanted to make sure in the old version, like when I went to college, Cliff Notes, when I couldn't understand a book, I bought a Cliff Note book. It was written in very simple English where I could understand it and hopefully pass the test. And I didn't want to be concerned with all what each study showed and which organization recommends this or that. I wanted to do what was the standard of care. I realized there's 9 ways to skin a cat, but when you have a certain condition, I gave all the medicines. I gave my algorithm. Now, is my algorithm always the correct algorithm? No, there's variance. Medicine is an art, and but at least gives patients a direction. And when they do go into the office and they haven't had this test, or why are they on this medicine or that medicine, and just challenge their doctor, because each patient has to look out for themselves. Because if they're not looking out for number one, which I always consider myself, or the patient number one, no one else is. So I think education with the patient, literacy, and they have this, I would call it more of a reference guide. It's not a textbook. but it is a reference guide.
Well, I love it. And actually, we will have a link to the book so people can have access to it eventually. And so they listen, they watch, they can click and go and check out the book. But so let's talk about what you mentioned, the relationship. I mean, the story, you and your dad walk in, going to the hospital and things like that. That's a little bit of a different art now. I mean, it's changed a little bit. And you're right. Hospitals have been getting, almost merger. There's a lot of mergers and getting bigger and bigger. And to your point, the private practice is different. And then you have the physicians that actually operate under the realm of I guess, a corporate, kind of health system, right?
Right.
And with those functions, to your point, I see it in New York all the time. And I work in the insurance, so I'm the payer. So that's a joke we got to talk about in a minute. but the fact is, same thing. Like when we have members of our own that go to these facilities, one of the common things that we actually hear all the time in complaints is that, oh, my doctor is not seeing me, or I'm not able to see my doctor, and I'm seeing somebody else. To your point, it's whoever is attending there at that time, whatever, and somebody that's just doing a rotation, and the main doctor is usually not there. I actually see that even with my mom's, for example, she for her retina diabetes, for like her eye diabetes, checkups. The main doctor, is there, but we only see him like literally about a minute. He comes in, he just checks everything that the other, student doctors are doing, and then that's basically it. I mean, that's exactly what it is. So we go through all these I guess, student docs, and they're just in the practice and learning and doing this stuff. And once they do that, then the doctor comes in and kind of evaluates what they did, and then he does a quick check, and that's it. And that's not a bad. Like, we can still see him, but to your point, in the primary setting, you might not even see that doctor for months or years because these other doctors are assigned under the main one in these facilities. So yes, you might have an ID, PCP ID 123, and that's Dr. Barkett, but it's Hurricane H actually that you're going to be seeing there. Every now you're going to go. So who's your doctor, Dr. Barkett? Who are you seeing Hurricane H? That's actually a little confusing. Now, I mean, imagine that, and it creates a little bit of stuff. And to your point, the level of that doctor may be not the same, or like you said. I mean, again. NPs have their own worth and they have their own education and they know a certain level. It's becoming almost competitive these days. Even NPs are, they're having these. I've seen that now when they went to the PhD level, it kind of changed a little bit the dynamics and I've seen actually NPs arguing with doctors. And so it's getting to that point. But again, I'm not going to go into the politics of it. I know there's two different schools and, I respect all. But truly for the patients, it's confusing, and it is. It's not. They don't understand everything. I mean, there's the patient bill of rights and all the stuff in these facilities, and a lot of things. But understanding the process, understand what you're going to get, who you're going to see, and what's going on. You get a prescription, they send it to your pharmacy, and that's about it. Sometimes you don't even have direction. How to use it. You go to the pharmacist, they say, well, whatever is on the prescription, I'm going to give you. But then you're still confused, and some of these things can be very not good for you, right? So the relationship with your patients. You mentioned something great. I mean, your dad knew everybody, and I get it. I mean, and frankly, that's how you expect your doctor to be, right? You want to talk to your doctor. They know you. They know your wife. They know your spouse. They know your kids. They know your family. They know your history. And historically, you want to be as a patient with one provider, for a long time, because that's the provider is going to know your health and your conditions, and they're going to go through your life with you. And actually, I find that very interesting because I work with the senior markets, so Medicare, beneficiaries, and for the most part, they're attached to these providers, and they're not going to change their doctors for nothing. So, we are an HMO concept, so therefore they have to pick a PCP. And unless one of the main challenges that we find is that the people cannot move to your plan because their PCPs are not on the plan, especially when you're talking to a limited network or closed network. So it's a challenge, but the relationship that they establish with these providers over the years, it's almost family members. They become part of their lives, and you're not going to change.
Right.
They're not going to change their mind. They're not going to do anything about it other than they want to see their doctor, and that's a big deal. The emphasis on that is important. I actually believe in it because you changing doctors, and the doctors don't even know what's going on with you. Sometimes you can't even get the records to move from one facility to the other, or they might lose the facility. It happened to my son. We requested the documentation, and the doctor says we didn't receive it. And like, okay, somebody's got that information, So your experience from the time that you did this with your dad to now has changed. Obviously, there's a big shift. What are the challenges that you have in addition to this in terms of like the modern way of doing this?
Hurricane, you just hit about 10 major topics that makes my blood
Oops.
boil. My God, did you hit them? I think the first part with relationships is I'm still a privately owned practice. So, and in my situation, I don't have to answer to an institution. And when you're when you're owned by a hospital, pretty much you have to refer as a primary care within that hospital system. Well, that's not the way I play. You know, in my book, I said, everybody's not the Tiger Woods or LeBron James of their profession. And if I want to send them to Cleveland, Ohio, Columbus, Ohio, heck, even to smaller places like just down the road, I can do that, which I feel very good. I am a dinosaur in that situation. But the other relationship part now is a lot of primary care physicians and especially hospitalists. Now, that has been the main key. When they kicked us primary care physicians out of the hospital, they felt, so they separated between inpatient doctors called hospitalists versus community or outpatient providers or primary care like us. Well, these hospitalists don't even live in the community anymore. You know, because I live in a town of about 60,000, but I think it happens nationwide. They're really, when my father was in practice, all the doctors lived in town. They were part of the YMCA, the Rotary Club, the Kiwanis. My mother had a medical auxiliary, and they're still in a bridge club together. I went to school with the other kids, and it was just a community where now, in this day and age, people travel and they don't really want to go to the smaller towns. So they're not part of the community. So you're not going to see them at Kroger's. You're not going to see them at a high school football or basketball game. You're not going to see them at a musical or the country club. So that is a huge change. And then when patients go to the hospital, they become very comfortable with their doctor, and they get to the hospital and they're taking care of physicians that have never met them. And then usually these hospitalists change on a day-to-day basis, and then they're seeing specialists. So now they're just inundated with people they don't know. Where in the past, when my father or myself walked into the room, there's a comfort level, even though they may have had a heart attack, they're getting chemotherapy for their cancer. So there is a comfort level. And I tell them, Dr. Smith will come see you. I really like him. I think he's the best in his profession. And you know what? Mentally, I can't even tell you exponentially how much that means to patients. But now when they're in there and it's just a whirlwind effect. And the crazy thing is, even though my hospital, and this is another topic you just brought up, is a quarter mile away, our computer systems don't even connect. So I can't go in the hospital. B, the hospitalists never call me to see, hey, what is the history of this patient? And C, when they're in the hospital, I can only get the information when they're in the emergency room. I do not know what goes on during their hospitalization. And when they leave the hospital, I still don't get a phone call. I may get a fax, and this you brought up all these points is where I think we're losing out in the relationship and the patient care, and it's getting more robotic, more technologically advanced, but you've lost the personal touch.
Wow. I mean, it is difficult, and you're right. Well, there's some new companies out there in the medical, when I say companies, I mean like these provider groups that are coming out with almost concierge medicine types.
Oh, yeah.
That's happening. I mean, I'm not talking about the ones that are, self-pays. I'm talking even like some of the government programs like Medicare and things. So there's organizations nationwide that actually do a similar approach where you become part of this site and you have your doctor and you build, this relationship. But again, to your point, if the doctors are moving and changing, in that facility, you're just basically getting a rotation, you're not getting the same person that you actually have established a relationship with. That's a big deal. And that's a loss. So as much as it is maybe convenient, it's better than going to maybe an inpatient clinic in a hospital setting. You'll have a different angle, but it's not the same as, to your point, the old. I mean, there's also the trend now. There's some groups that are coming back to the original medicine where they actually do visiting doctors. They go to your home. And really, that's the old school, medicine, when, doctors literally carried their little, bag.
Little black bag.
Exactly. And they went door to door. So there's different, touches right now, because to your point, it's changing, and some doctors are more aware, and they adjusting differently to how it is. But you're right. At the end of the day, the bottom line is your advice. And I think everybody should be clear about this, that you want to have that personal relationship with your doctor who would know everything about you, your family, your heritage, your DNA, everything. I mean, and they'll know how to work with you to sometimes even prevent things from happening, because you can, for example, bypass your doctor, the other guy comes in, or gal, and you get the wrong information, and there you go. Things have shifted, and a different opinion, different approach, different school of thought, and it can just shift everything, right? Not good for you.
No. You just reminded me of one of my patients, and I didn't know it, but this one guy, I couldn't control his blood pressure at all. And I tried everything. And I was just ready, and as a primary care, you got to know when to, you got to know what you don't know. So I was just ready to send him to the cardiologist. And he goes, my sister comes here. And I go, really? What's her name? And he told me her name. I'm like, and she had high blood pressure. So I go, well, geez, let me see what she's on. So I went to the chart. Well, back in the day, we had paper charts. So I didn't have to look through the computer, which that will probably be a subject coming up with this electronic medical record that's ruined primary care. But I had the old paper chart, went in the back, looked at it. I said, you know what? Let's do it the old fashioned way. If it worked for your sister, let's see if it works for you. 1 month later, he was cured.
I guess it's genetic.
Yeah, it's genetics, just like you said. I hadn't thought about that in years, but it was.
Well, again, I mean, but these are the things that you will not know if you're going through just a random doctors that just check you. And the other part is, I know that you probably spend a lot more time than an average doctor in one of those clinics. And by the way, not putting anything down, but like, for example, in the city, you got thousands of people lined up in these, and again, this show is international. So in some other parts, forget about it. How long does it take you before you can get an opinion, an appointment? I mean, right. I've had guests, from Canada, and we talked about the healthcare system there, where you have to wait a certain period of time before you see a doctor. So similarly here, you have the same thing in New York City. We have a lot of facilities where you have to 2 months, 3 months before you get an appointment. When you go there, the wait time is crazy. And the doctors have maybe 10 minutes to come in and talk to you. Right. There's not much you can do really to actually establish a good, visit with a doctor in 10 minutes. And that's a challenge. And so that's why I said, like, some of these new products that are becoming, more common in the cities, now they actually kind of go back to the concept where I'm going to give you your 25, 30 minutes just with you, one patient at a time. And so they have limited amount of patients per day, and therefore they can do better jobs in terms of spending the time. But that's, again, it's just small, fraction. The majority of people are still getting processed through the main, system, which is basically just, patients in, patients out. And that's the other. The other part is, and now I'm going to probably hit the wounds a little bit, which is, insurance, the payers. I mean, sometimes, there's a big problem because they don't pay, especially for Medicaid and Medicare and stuff. The scale is low. And so the doctors cannot survive on peanuts. And let's be right. And I'm not putting down the insurance industry. I'm just saying these are facts. And so especially if it's subsidized, insurance, like in our case, like what I work, is it's all subsidized by the government. So you get a subsidy by month, you get a premium per month per member, and you have to do everything with that, admin fees and all the stuff, the care management stuff. So you only have a certain allocated dollars. So the pay to the providers is limited based on whatever services they have in their specialty. So it makes it very difficult. Doctors don't really like that, some of these plans, and because unless they get a certain amount of premium per month or some sort of a fee, they're not going to be happy. And therefore, even if they participate by default or by just by wanting to be in the system because they have no choice.
Right.
They do it, but they're not really happy about it. So they prefer a self-pay or a private, insurance or commercial insurance than one of those programs. So it changes the dynamic. So again, understanding that you're in a smaller town, so maybe the real estate is different, the expenses may be lesser. I'm not saying that's the case because the world is is on fire right
Right.
now. But the fact is, for example, in the city here in New York, it's costly, and it's hard to maintain, so therefore the charges, the fees are, and I can tell you over the years, I mean, again, like you, I've been doing the insurance part 29 years, so I've been on the other spectrum of it, and I've seen it change, shift, and the even the reimbursements have gone down. The doctors are getting less. The Medicaid, the Medicare rates are lesser than ever. So it changed the whole thing. So a lot of providers don't even want to participate anymore in some of these programs because I want your Medicare and your meds up. Give me your ARP card.
Well, unfortunately, medicine's still a business, and, especially when you're early. Well, the new doctors coming out, they're probably on average $200,000 to $300,000 in debt. And, they don't have the and unfortunately, they don't have the luxury. You have, say, Anthem, for existence, and maybe you're a private practice or, a small group. You don't have the power to negotiate, so, it's either you take this fee or, you lose 500 patients. But you have to make a choice. We went into this field to help people, but also, you've worked till you're 31 to 35 to finally get a paycheck. So you do want to be, financially secure, at least at some point in time. And that's why I think in hospital-owned practices, they force you, they call them RVUs, relative value units, where you, like you said, you have to be in and out in 10 minutes. And you're not going to spend the time with patients. But, I hate to be the old, guy that says, hey, solo practice is the only way to go. But, when, as someone said, I can work all day long. I mean, it doesn't matter. So if a patient is sick, I'm not going to make you wait a week or 2 weeks or a month. I'm going to be there. I mean, I start at 8, and if I have to work till 7, I can work till 7. I just don't want anyone going to an urgent care. These urgent cares now have also been diluted across the country. There may not even be a physician in there. And as like you, well, you keep bringing up insurance, but sometimes in my practice, in private practice, someone comes in with low back pain, or I have to follow algorithms to get the MRI. But if you go in rooms or with a hangnail, you may get a CT CAT scan from your head to your toe, and who knows what those costs are. But I think in the future we got to go back to the model of the primary care, better reimbursement. My pet peeve is that a patient like today came in, they had a rash and they had shingles. If they had their copay of $20 and their fee, say, was $80 here. And if they saw a dermatologist in the same town with shingles, the same diagnosis, their copay was probably $60 and they got charged $200. So that's where I think insurance companies have to somehow split the difference. Stay with the primary care. We are at the front of everything. And why is the pay difference between, the same diagnosis if they're going to see their primary care versus a dermatologist or subspecialist? And I think that's where you would get better quality of physicians staying in the primary care versus knowing if you are a subspecialist, you're going to get paid a lot more money.
Well, doctor, thank you for that. But in the I want to give another comment on that one. The way it operates on at least the HMO business or the managed care concept right now, I mean, we do emphasize on the primaries, primary. I mean, we want the primary. We don't want folks to go to specialist originally because the primary will determine if they need a specialty or not, because that's what happened when you have free access. You feel a little heart pain, you just go to a cardiologist, right? and you get all these
Right.
EKGs and everything else. Well, meanwhile, it could have been just a heartburn, but you don't know that until you go to your primary doctor. So we always try to educate folks. Listen, you want to select your primary, make sure you see your primary, do your preventative, do your checkups, and things like that. And to your point, also, we don't want them to end up in ER. And unfortunately, historically, some people don't go to the doctor, period, until they're sick and something happens and they end up at the ER, which again, it pushes the cost of insurance high, and therefore that becomes a problem overall. Because when someone is constantly, wound up at the ER, it's costing thousands of dollars to the insurance carrier, and therefore now they have to somewhat to recoup that money, and the rates go up again, especially in the commercial world, right? It just how it is. The cost, like there's no cost that is diluted. It's always going to be back to the actual consumer somehow, and so.
Correct.
And that's really the problem. So when people are not educated enough to do the correct way, which is your primary is your primary. That's the first person you're going to see it all the time. ER is really for true emergencies. You're having a heart attack for real. You're having, a stroke. You have a broken bone. You're bleeding. That's where you go. You have a little headache. You can do some Tylenol if it's working. I mean, I'm not, giving a medical, diagnosis right now, but the fact is, it's that aspect, right? You have to think about what you have, call your doctor. And most of the doctors, they may have some sort of nursing service, pick up, service after hours. At least they get a triage. And if you need the doctor, they'll call the doctor. There's so many possibilities out there and services available. So you don't have to always wind up at the ER or urgent center, to your point. Now, urgent centers, you're right. They're popping up like mushrooms everywhere. And good business from a business perspective, they're good. They're handy because their hours are later hours. They're not an emergency per se. So they do handle some mid stuff. But you're right. I have yet to see an actual physician in there. I've seen a lot of NPs and to your point, medical assistants or I guess provider. What did you call them?
This is nurse practitioners. Yeah.
Yeah. So, but the main ones usually are NPs. And again, like I said, nothing wrong with them, but it's a different level of as I guess medicine. And again, some people will argue that like they have the same quality, doesn't have the same education, not the same but similar. They know exactly, they can prescribe prescription. So there's that debate, and one day we'll have maybe an NP and a physician and have them duke it out on the show.
Right.
But that would be an interesting show. But the fact is, I try to respect everybody in their profession. But you're right. There's a certain protocol and steps that need to be met. And I think from an education perspective, if people aren't aware of what needs to be done, and if you do in your regular checkups, there's a good chance you're going to be always in the preventative mode, and you're probably going to avoid unnecessary hospitalization, emergency visits, and things like that. And so, I guess your book has those pointers as well, if I'm not mistaken.
Well, I think, I've had arguments today already with my patients. I feel my patients should respect me, but I'm not going to give in to them. And a big portion of my book is just what is proper care. I think there's a lot of polypharmacy, meaning doctors are prescribing too many medications for each condition. And they come in for one thing and they give them medication, then there's side effects of that medication. So they give them another one to counteract, because I'm also a hospice director and a nursing home director. So I do get to review a lot of charts, which I just think the most part is too many medications. But, my patient today, she's 81 years old and she has, multiple medical problems, and she wants to get a sleeping medicine like Ambien. And I just told her, I said, if I give you this Ambien or Xanax, benzodiazepine or something, I said, you could sue me. And so like a big portion of my book, which causes arguments with patients every day, or it used to cause arguments with nurses when they're calling me for the hospitalizations of my patients and they wanted certain medicines, or from the nursing home now. It's called the Beers criteria. At BERS. And after age of 65, there's just certain medications that most patients want that just I cannot prescribe. And that's why sometimes my patient, as a side note, there is a Press Gurney scale. And at our local hospital it's a big hospital, but it's owned in Columbus, but it's called Ohio Health. And part of the physician's bonus scale was what their Press Gurney score was. And if your Press Gurney score was high, you got a bonus. But when they did the studies, the higher your Press Gurney score, the lower the patient health outcomes were, because it's patient satisfaction. A patient comes in with and wants narcotics, and you don't give them to them. Well, your Press Gurney score is going to go down. But in this situation today, a sleeping medicine, which it's not on the Beers list. And if I gave her this, she would get up confused in the middle of the night, trip, fall, fracture a hip. And so now when my patients come in, I don't have any problems with saying no. Are my patients going to be happy because they have some pain and I can only give them Percocet maybe for a week because they've had recent surgery, or maybe I don't give it at all. They're over 65 and they want Xanax. They want a sleeping pill. They want a medicine because, as people are listening here today, or mostly more women, they cough, sneeze, urinate, and they're leaking urine and they want medication. Well, the only medication that I can give that is safe for over 65, say, would be Myrbetriq. Well, Myrbetriq's more expensive and the insurance companies won't cover it, and so, because it's an anticholinergic, the other one, the cheaper ones have anticholinergic side effects, which you can't give to the elderly. So there's probably, or just for way more common, you're over 65 or 70 and you have a hip pain, you have back pain, you have knee pain, you want to start eating, Motrin as your daily breakfast. Well, these non-steroidals can cause heart attacks, strokes, ulcers, hypertension, kidney problems, and I can't give them. And they're like, well, doc, I take Tylenol, it does nothing, And so, well, there's other options we can have. But so on a daily basis, I know I probably disappoint my patients, but I know I'm doing what's best for them. And I think that is another reason why my book, Simple Medicine, No More Google Searches, can help explain, some of the discrepancies of what patients want and what doctors should give. And I'm not, at least in my position now in my career, I tell them, I'm not your friend, I'm more, this is not a friendship. This is more of a patient-child relationship. You're trying, you're going to do what's best, and I'm not going to give in to what they want. And, unfortunately, doctors want to be liked. They don't want these institutions now, because these Press Gurney scores. Well, Dr. Barkett said, no, I'm in pain. He wouldn't give me Percocet, this or that. I mean, you could even check out some of my Google reviews. I had this actually guy that went to high school with me who was a known alcoholic and chronic pancreatitis, and I wouldn't give him Percocet. And he wrote a Google review that made me look like I was Satan.
Oh my God.
You want to do what's best for your patient. And there's just times where doctors got to say no. And now in my book, for every common condition you can have, or, the most common, the correct medications are in there. There's an algorithm. I give the few side effects that each medicine may have. And when you reach 65, what are the medications you can have, and what are the medications you can't have? And I think when they go home and they're mad at their doctor, mad at me, they can review why that decision was made.
Well, Doc, thank you for sharing that, because that is a big element. The fact that you are willing to get, you're risking, like to your point, the review, whatever, because you believe that's what's right for them, and you're not afraid to just tell them it's okay because you want just to have to please them for the minute and they can walk happy. You're right. This is not a tantrum. Can you give me this, hook me up, doc? It doesn't work that way. You know what's best, and to your point, you are responsible for their health in a way, because to your point, God forbid something happens to them, or you give them something that's not going to be good, and then you're in a trouble, because now your malpractice, whatever can happen, and things like that. People don't realize the risk that you guys have as a provider, and we have to appreciate that. I mean, You talked about the cost of education. Add to it annual cost of malpractice. Forget about
Man, you just trying to get my blood pressure boiling here tonight.
it. I'm not worried about you. You can prescribe something for that, right? But you know what I mean. I mean, it is a tough business, and people may not realize that. And you're right. People sometimes they just. I talk to my friend. Well, my doctor. I went to this clinic. They give me this. Oh, let me talk to my doctor Barkett. He's going to hook me up. I show up. It's like, no, that ain't going to work. I'm not doing this. Why not, doc? People have to be sensitive to what that means, but they may not understand all the time. There's a risk, but you are doing what's best for your patients, and that's the most important thing. And I think that is honorable and noble because not everybody may be at the level where you can tell people, no, you're not getting this. And that brings me to the question of again polypharmacy, whatever the term you used.
That's polypharmacy, exactly.
So polypharmacy, just prescribing stuff. No, so I know there's a big debate. I know pharmaceutical reps are pretty much friends with the docs, and they hang out with the docs, and the tradition has been you guys go out, and I'm not saying that you do, but it's normal. There was a whole different discussion about these things, and topic has always come up. Where you have these relationship, the pharma company, they send these agents, and you guys work with them. They give you these demonstrations and so on and so forth. And some doctors may just take the prescriptions and do it. Some doctors may not. That depends. I guess that's a personal choice, a doctor's decision. What would you say to that? Because that's usually a big, I guess flag or a big discussion topic where people always like pointing the finger, especially people that I've seen it. You're a patient in a clinic at a facility, and then you got these reps that come in, and you got like 2 or 3 of them coming from different. They spend more time with the doctor than the patient sometimes.
Right.
So what would you say to that? I mean, ultimately, I can see that you're not one of those. I mean, I'm sure you have your relationship with the pharma, and you get the prescription, and you get to learn about them. But you are selective as to what you give based on the knowledge that you have and what works and what doesn't. But do you think that, there's a better way, there's a good way to do this versus a bad way?
Well, Big Pharma has changed dramatically. And I have to say, I was a big fan of Big Pharma when they would take me to Cleveland Indians games or, concerts, or take me to a nice golf resort. Went down to Miami and played the Doral. And back in the day when insurance companies would actually allow us to write the medications that we really wanted to write. So back in the late 90s and early 2000s, when Big Pharma was big, we had Pravachol. This is an example of high cholesterol medicine. We had Pravachol, Zocor, then Lipitor comes out, then Crestor comes out, and we wanted to write those products, we could. And other hypertensive, there's probably 8 different angiotensin blockers that were out there, 5 different beta blockers, and there was a lot of me too medications. Like, does it really matter which one of these statins or ACEs that I use? And, you have a relationship with a certain company or a certain representative. Yeah, you may have been or could have been swayed, but I knew I was not doing my patients any disservice. Well, Big Pharma's changed now. Unfortunately, they can't even give us a pad of paper or a pencil now. They can maybe come to your office and have lunch or go to a dinner party, and where they have a speaker. And no longer are insurance companies really allowing us to write any branded medication. It's all generic for the most part. But even right now, I would say that there's some really, really good new medications that the insurance companies have been allowing us to do. But I think the doctor has to see what the best data is. Just let's go to the diabetic realm right now. And diabetes, which is rampant amongst America, the world, obesity, and the changes over the last 10 years have been dramatic. But there is a new class of drugs called the SGLT2 classes, is the SGLT2 class, which would be Invokana or Farxiga or Jardiance. And there's huge competition. And, and it's really difficult for the doctor to know which ones to use if you don't see a representative. Like I luckily I see the drug reps, but a lot of people don't. But which one should you use? Well, you have to use the one that decreases the risk of coronary artery disease, cardiovascular disease, renal, not renal failure, but a renal dysfunction. And it's really tough to keep up on this unless you do see representatives. And when the push comes to shove, and say if something goes wrong with your patient, I always think what a lawyer may say to me. Well, doctor, you use this drug. Why didn't you use that drug? And, so I'm just afraid of any lawsuit. Knock on wood, I've never been sued, but I want to back my decision up with science. And in this day and age, with the changing of medications and keeping up with everything, I want to have solid information behind me with data that tells me why I am using that drug. And that's what I do in the book. And the other big classes of drugs now is, thank God, warfarin or Coumadin, the blood thinner, is kind of rat poisoning. If you look at it, if you go to Canada, and it's got a big warning sign on it, and they've come up with Eliquis and Xarelto. But that's a big belt. That's a big area of now for anyone that has a clot, a pulmonary embolism, peripheral vascular disease, atrial fibrillation. And, the data is sometimes very difficult to decipher. One, I would never use Coumadin the rest of my life or give it to a patient unless it's just a cost issue. But then when you're trying to figure out if it's Eliquis and you want to use that twice a day, or Xarelto, and, one study says it's non-inferior to Coumadin, the other one says it's superior. You have to make sure you are doing what you feel that doctor feels is absolutely best for that patient, and try not to let the relationship with the representative, come into play.
Well, I appreciate that, and thank you for the honesty about it, and your ethics about this, because I think that's important. To your point, I mean, relationship is one thing, but what's good for your patient is the priority, and doing the right research and and investigation, and also learning about those interactions, whatever is important before you make those recommendations. And you're right. I mean, the other thing you mentioned something about the insurance and the authorization of what prescriptions are allowed or not. I mean, most of the companies now, they have tiered levels, and to your point, generic 1, generic 2, preferred generic, and generic. And even the brand is preferred brand versus just a regular brand. So you kind of like, you have 3 tiers before you get to the actual one. Then you have all these step therapies. If you want, sometimes they allow you to do those before you can get a certain prescription in. So there's different things that are in play in a way to control the cost for the insurance. But you're right, it makes it a little difficult, and sometimes it's limited. And I know that you're sometimes forced to even recommend different insurance carriers because this one doesn't carry this prescription on their formulary, the other one does. That's a challenge. You need to even be an expert in the health plans.
Oh my God, you got that right.
Well, I hear it all the time because we meet with doctors all the time, and one of the things, like they want to learn about the plan offering and the formulary, what's covered, what's not covered, the authorization process. That's always a big deal. Now, you talked about faxing and stuff. Now they have portals. It makes it a little different, from the old school. You said something about MRIs and things like that earlier. The authorization process can take up to two weeks in some instances, and someone needs that stuff immediately. That's a problem. So it is a tough place you guys are in. I'm sorry, Doc, but I know you know how to handle it. I mean, obviously you work, in this world, and you understand it, well enough to navigate it, and I'm sure you have folks that can help navigate this. But I love the concept that in the book you kind of making it step by step easy. And you're talking about the diabetes, you're talking about, the resources, what's working, what shouldn't work. Is there anything else in the book that we haven't covered yet?
Well, I think a little bit is how a patient should pick a physician. I think in any area you are, there should be a little research. I think they should look at their credentials where they went to medical school, where they did their residency. And once they get into the office setting, I think patients must realize that when you get in there and a doctor, one, I think there should not be a communication barrier. It's hard enough in medicine because we're already talking Chinese to the patient anyways, that at least they can understand what you're saying, even though, they can understand the word, they might understand what you're saying, but, and then you have to have a comfort level with your physician. And then I wrote in the book, unfortunately, a lot of these young physicians, they'll go through a whole physical and they won't even put a stethoscope on their patient. They won't touch their neck. They are not, putting the stethoscope, listen to their lungs, their heart. They're not doing rectal exams for prostate. They're not doing, pap smears for women. I mean, if it's, they're not covering, it's hard for the patient to know but they can't be shortchanged. The doctor's got to be in there listening to concerns, doing full physicals. And I think, when they go home and that they have certain conditions, I think they should look at my book, Simple Medicine, No More Google Searches, because if they're not, I think another big thing about the book is they can look at it and say, well, I'm a certain age. What cancer screening should I have? I mean, how long should I have a pap? How long should I have a pap smear? When should I get my colonoscopy? How long should I get it? When should I get a PSA for prostate cancer, an exam? When should I get a CAT scan for my lungs if I am a smoker? I think if the doctor didn't talk about immunizations and what are the common immunizations, I'm keeping the coronavirus out of here. But, a shingles vaccine for everyone over 50, a pneumonia vaccine. And there's now new pneumonia vaccines called Prevnar that's out there. If you have a chronic condition or if you're, 65 years and over, flu shots, who and who shouldn't get flu shots. There's a lot more, in preventative care that patients don't know of. And I think that's key to my book. And then, things that people think they're all alone about. We haven't touched on it, but like depression is huge. Dementia in this age as patients are getting older with dementia. And I think it's real key to know as not the patient with dementia, but, the caregivers. And if they can look and, and just get some solace to know that they're doing, what's going on in their parent, their spouses, their kids' life is, and to go to that section and know, it's not, I'm still back on dementia, but, it's not maybe the same person you knew. And to have patients or like drug abuse and alcoholism are in the book, but everything is very short. And like, with alcoholism, it goes over a little about Al-Anon for the caregivers, AA for the alcoholic, or if the alcoholic goes off the wagon. There's just all little tidbits that can make you look in that book and say, because everyone thinks they've done it wrong or they're not being supportive of that patient, but to just give them some comfort level, like, geez, this does happen. Are we still?
Yeah, you with me, just no visual.
Oh, okay. And so,
I don't see you, Doc.
Okay. Well, someone's calling me again.
No worries. We'll pick up from there. Don't worry.
Okay, hold off. I'm not going to touch anything. This call should end.
Yeah, you're a busy man. What can I tell you?
Okay, we're back.
There is. Listen, it happens. No worries.
Yeah. So the book is broad, but every one of my patients who I've talked to have read it. It says it's easy reading, it's fast, and about any major topic you can go to. And I think it will help you understand a little bit about that condition, either from the patient standpoint or from a significant other standpoint.
Well, again, I'm gonna check it out, and we're certainly gonna have the link to it, so people please do so. You did mention something important about the fact that the doctor should do the preventative, a full checkup, full workout, things like that. But it's funny because in most of the carriers, insurance carriers do now. There's even incentives for doctors to actually do those things, and they get paid extra to make sure the doctors are getting these things in place and checking. Because now especially in the government programs, you have CMS and you have star ratings, and there's HEDIS measures, and you have to meet all these criteria. So the doctors are incentivized to actually get these things done, and I'm surprised that it's not happening at the rate that it should be, for example, or at least, based on the discussion here, it sounds like not everybody's doing it. And we can tell, I can tell from our side, when we look at the different doctors we have thousands of them, not everybody is doing the same, you know what I mean? And some doctors do better than others in terms of like what they prescribe and how they do it. Do they do physicals? Do they go over all the parameters and things, the metrics that are in there that are supposed to happen? So that's a big deal. And so again, it is something out there.
I do want to give props to the insurance company on this. Over the last 3 years, 3 to 5 years, there's been a huge uptick in wellness or preventive exams where patients will get reimbursed, their insurance premiums will go lower, and they're pretty much forced to come to their primary care once a year. That has been huge, especially the people that would not have come in for every 2-3 years. I love that, and I really got to applaud the insurances for those. And then even for Medicare too, they're welcome to Medicare and their yearly visits there. And the other big thing I really want to say the insurances have done well with is after hospitalizations, if it's a major problem, they have to see their primary care physician in 1 week. If it's not so major, within 2 weeks. And that's really helped to reconcile medications, reconcile what's going on, and really help prevent readmissions to the hospital. So I really am thankful for the insurance companies for what they have done probably over the last 3 to 5 years, and making these available to their consumers.
On behalf of the insurance out, thank you. but you're right, and you said something very very important there. You're right. I mean, we do that process, especially post discharge. The care managers have to connect, with the doctors and make sure everything is done and the follow ups. So there is work that gets done behind the scenes, and so most of the plans now have teams of care managers that are actually on point with these things. And again, it depends on the carrier, it depends on many things, but typically you're right. It's been a very big trend, especially now again with all health plans now. The majority of them are being scrutinized, to the ratings and things like that. So they have to do better and make sure that the folks are healthier in a way. I mean, ultimately, help from a financial perspective, you want your patients, your members to be healthy and not sick. Right. Health plans don't want the patients to be in the hospital or the emergency room. I mean, that's just the cost, right? We all know that it's no secret, and so therefore, we'd rather pay for someone to see the primary than to see a specialist or subspecialist, or even wind up in a long-term facility. So that's not something we want. And again, right. When I say it, I'm talking just as an insurance person right now. But that is the standard. But at the end of the day, we are on the same mission when it comes to that, because if you look at it this way, we want the members to be healthy. You want the patients to be healthy. And I think that's one thing that we can agree on 100%.
Absolutely. 100%.
There's no disconnect in that one. So that's the good news. But, listen, I mean, there's a lot of information that we've talked about today, and thank you for sharing all that. I mean, we're coming to the end of the show, but I think you've covered a lot of angles, and you talked about also the preventative measures and the things that are available, like the immunization shots and things like that. Many people sometimes don't know why they should do them and how, and the skeptical stuff. I mean, obviously, we're not talking about COVID. That's a different discussion. But certainly the standard ones, the flu shots, the pneumonia, and
Shingles.
shingles. Yeah. So those are the things. And I love the way that you broke it down by age, because like, for example, when I turned 45, I think prostate became an issue.
Right.
I just had my physical literally last week, and now we're talking colon, what is that, colonoscopy, whatever they call it,
Colonoscopy.
colonoscopy. So actually, I got the kit.
Oh, you got the colo guard.
I got the kit. So it's in the box. so like, oh, I gotta adjust, So I guess every decade you adjust to something new. But you're right.
Right.
These are the things. So my doctor is, I love him. He is very thorough. He explains to you everything correctly. He just what needs to be done, why. And that's the other thing. I think by understanding the why, the patients can be a lot more open to do whatever those recommendations and execute. But if they just say, "Oh, I need you to do this," sometimes people are reactive just by default. We always say no. I mean, humans are no by default. You tell me something, I say no. So, but if I tell you why and what's your benefit, there's a good chance you're gonna understand it. And now you can operate better. So your approach, I think, is what that comes from your expertise and the words of that yours actually, that you've been out there doing this, and certainly it's a different approach, and I guess you today, if you go back to your younger self, there's got to be things that you've changed over the years.
Yeah, you wouldn't recognize me.
I believe me, I know exactly how that feels, because I'm in a leadership role, and when I started to now, I'm a whole different person. And I think also a younger doctor, and also I guess the education has changed, and maybe there's different things. And so I can't speak for that, but certainly in time, the wisdom comes in, and you can see life differently with a different lens, and whether it's just personal life, regular life, or otherwise the actual concept of medicine here. So any last words of wisdom for today's show?
Yeah, I would just like to encourage, the patients to take interest in their own medical care. And with interest, I'm talking about literacy and education. I think if they know and can understand what preventive care really means in this day and age, and it's really not that complicated. And if they could, go to simple medicine, no more Google searches, and just understand simply why we are thinking what we are thinking. And there's no book out there that's written in a very simple fashion for the patients. And it's easy to understand. It's written in 8th grade English. And then they will be able to challenge their physician if things aren't being done, which are standard of care. And, they're going to have better health outcomes, and they're going to live a longer, happier life, and hopefully with less medications.
Well, thank you, Doc. And I was, as you were talking about, I was thinking about something else. We're talking about insurance, and since we're always a partner when it comes to healthcare here, I always thinking out of the box and try to figure out how we can also improve lives, from our members' side, which will be your patients. But I mean, this book could be a good tool for health plans also, and maybe that can be something they can include in their education and send it out. So maybe I'll talk to my folks and see if that is an
Hey, I would
opportunity.
appreciate that, Hurricane.
Well, again, I'm telling you, I'm on the air right now. I can tell you, folks, if you are in the managed care or health insurance, and you hear the show, maybe there's an opportunity here where this book can be the standard, measure to give to patients to kind of learn, just to educate them a little beyond, because whatever we give is not enough. I mean, we give them contracts, and they're very, thick, books that probably I can't even read, so cover to cover. I mean, it takes me days, and it's written, in a very complex, as well. I mean, I don't think it's complex. It's supposed to be like 4th grade, language, at least for the ones we provide. But it's still, very complex books. But to your point, these are the basic things, how you operate with your doctor and so on. So maybe the book can be actually adopted by the health plans industry and the carriers, and there could be stuff. Maybe listen, I'm endorsing it. I haven't even read it yet, but I love what the mission of it, and at least what it sounds to be. So hey, maybe that's something that could be done. Maybe you talk to your friends from the HMOs there and the carriers, and that could be a new venue for the book, and definitely will get more people, because these helplines, they have a majority of the people somehow, and they can reach out to many, many people. And so if the cost is not expensive, I think that could be maybe even a digital version of it. I don't know, but
Yeah, it's on Kindle. It's on Amazon. It's on most of your common book websites. It's, 17.95, and I think really if every household would have it, I truly believe it could help not only you but at least a family member. And it's just a quick reference guide, and it's easy to understand. And that was my goal.
and doctor, I think this is not limited to the U.S. I think the advice you give, it's pretty much global, so anybody can actually really use it.
Oh,
so
yes.
so I think that also expands the realm where this book can be utilized properly. And certainly, have you considered maybe translating different languages? And I don't know, that's just another suggestion, but I think that people should know about this in all languages.
Yeah, I think, again, it's the only medical book written for medical reference guide, I would say, written for only the patient.
Yeah, we can't say more. I mean, no more. I mean, I think that covers it all. Well, folks, you're listening, you're watching, you are somewhere, somehow a patient yourself, or you have family members that are patients. I mean, I don't think someone that's living is not a patient to a doctor. We all
That's
have to
right.
see our doctors. So I think we all could benefit from the advice in the book and from the advice of Dr. Barkett here. And so please do, check it out. And if you like, you can comment, you can send us, and you can also go straight. Doctor, do you have like a website where people can also reach out to you?
Yeah, it's simplemedicinebook.com, and very easy, simplemedicinebook.com, and they can reach out to me at any time. They can, buy the book there, write a review if they like it or don't like it, and I respond to everything.
All right. Well, Doctor, it has been a great, show and great information, great insights. Definitely love the concept of the book and our exchange today. So, just want to thank you for being with us.
Well, you're a great host. You're a wealth of knowledge yourself, and you have a great way about you. And your listeners I think they're just so glad, unbelievable to have you there to spend a lot to get the common education that they should have. And you're just very good at the way you present it.
Well, thank you. Coming from me, I'll take it again as a compliment. I wouldn't say no to it. Thank you so much. Again, the mission is to educate people and enlighten them and inspire and motivate them, give them the resources. And I think, this is exactly what it is. And I believe in it. We need to help more people be educated. And I think knowledge is power. And some people can argue about that. I've actually heard in a discussion that's not necessarily true. There's more to it, but I mean, there's philosophy behind it. But in the basic terms, the more knowledge you have, you can have more empowerment to do things and be able to act better. So can argue with that one. All right, doctor. So thank you so much, and we'll be in touch. And for me, folks, thank you for watching, for listening on the radio here, and we'll be talking soon. New day, new show, new guest. Bye for now. Ciao, ciao.